Thank you. My name is Torben Skarsfeld, and I'm COO at Serodus, a Norwegian biotech company, a virtual company like many others today. We are privately owned. We have been on the Norwegian Stock Exchange for 3.5 years. We went public in 2013, but we left the Norwegian Stock Exchange in 2017 because not being a cancer company in Norway, then it's very difficult to raise money. So now we have private investors that are supporting us and have brought the company and our products to the stage where we are now. But now we are facing larger clinical trials, and therefore we are about to raise more money. Sorry, that way. Serodus is working within diabetes, not lowering blood sugar, because many other companies, they're able to do that much better than us. And the treatment is very good with all the new compounds that are there around. But we have a focus on diabetic complications. And primarily, we have a focus on diabetic kidney disease, on diabetic blindness, and also on food ulcers. But today I will primarily focus on kidney disease because that is our most advanced product, SER 150, that is aiming for this one. We have a patient in focus here. This patient is in dialysis, has had diabetes for many years, even well treated. Many patients will end up in dialysis, and ultimately these patients will need a kidney transplant. This is a very, very expensive treatment, being in dialysis 3 times 6 hours a week, and for the society and for the patient is very cumbersome. Diabetes is increasing worldwide tremendously. In many countries, US, but US is not the worst, but also India, China, Brazil, many more patients are coming, and you count the diabetic patients in millions. A proportion of these patients, they will go into dialysis and also need this kidney transplant. And what we want to achieve with our product here is to prevent the deterioration of the kidney. We have a market, a huge market. We have a product that we believe is working within this indication, and we have a very seasoned management, Eva Steines as a CEO. She was previously called the queen of Danish biotech because she established Zealand Pharma in 1809, I think it was. It's worth 6 billion Swedish kronor today. So they are doing very well, still around. Myself, I've been around for more than 30 years, nearly 40, September, being with large companies, pharma companies, and also US biotech. So we've been around, both of us. Diabetes, when you treat diabetes, you lower the blood sugar. And that's the normal way of doing it. But diabetes is other things than just a high blood sugar that you want to control. Diabetes is actually a low-grade inflammatory disease. And the side effects that we are talking about are actually caused by this low-grade inflammation. So there's an overweight of the inflammatory cytokines in a diabetic patient, even under treatment. And the anti-inflammatory cytokines, they are less. They are not able to compete with this heavy weight of inflammation. So in both type 1 and type 2 diabetes, we have a circle of evil things, circulus vitiosus, that is increasing all the time and involving many of inflammatory components, thromboxane, TNF, macrocytes. So you can see it on the slide. It is a circle that is running all the time. What we believe is that adding SER 150 into this patient we can break this circle because SER-150 is a thromboxane antagonist, and it has shown some very interesting data I will show you in a moment. But also, we were out to look for, is SER-150 also active on TNF-alpha and TNF-R1 and 2? So we took we made a study. Is 150 active on TNF-R1? That's a very important component. Can it inhibit this in a study? We made a study in rats, and this rat has lost one kidney and 9/10 of the pancreas. So after 2 weeks, is heavily diabetic, has a very high blood sugar, is able to survive maybe 10 weeks without any treatment. But what we did was we treated these animals. The group that was operated, we also have a sham operated, that's a low line. But with the group that was operated, the line all above, they had an increased TNF-R1, but then treating them daily for 8 weeks with SER-150, we lowered the TNF-R1 significantly here. So therefore, we have shown that not just is SER-150 a thromboxane antagonist inhibiting that part, but it is also working on TNF-R1. So we were very encouraged with this profile. We actually did a study some time ago there. And this study is in 72 diabetic patients. We didn't have any focus on TNF-R1 because that is recently popped up in literature. But what we did was we took these patients, we made 3 groups. We had a placebo arm and 2 arms with 15 and 30 milligrams BID of SER-150. And then we measured the ACR, the albumin to creatinine ratio in patients, which is a standard measurement in patients. And we found actually that SER-150 was able to significantly decrease from baseline on each patient, decrease the ACR, both on the 15 milligram and also on the 30 milligram. There were no difference between the effect of 15 and 30, but there was to the placebo group, which you can see is actually increasing slightly. This was a very remarkable effect. And the most remarkable is that this was only a 4-week treatment. On the right side of the slide, we have taken patients. Out of these 72 patients, 48 were treated. Out of these, 11 patients had macroalbuminuria. That is above 300 milligrams per gram, and that is a severe condition. And all these patients, you can see the difference between the baseline value and the treatment value. That's a solid bars, and that was highly statistical significant decrease in these patients. So if you just take these numbers, they're small numbers, but 45% of these small numbers, they came from macroalbuminuria into microalbuminuria. 25% of the microalbuminuria patients, the rest of the group, I haven't shown that, they became normal albuminuria. So they had a normal level of albumin in the urine, and that is below 30 milligrams per gram. So the challenge here is that many have done studies on diabetic patients, and these studies, in order to increase the function or slower the decrease of the kidney function, and these studies, they are running for 3 to 4 years, and they have thousands of patients. Very, very few, I think it's only one study that recently was published, has shown effect on this one. And the challenge that we now know, and this is new knowledge, is that if you have patients, diabetic patients, you have various degrees of decline. So you have slow decliners and you have fast decliners. The problem is you don't know how many slow decliners you have in your study population or fast decliners. So if you have a population of, let's say we just take diabetic patients, 80% of these patients, they are very slow decliners. So therefore, if you want to have any effect on these patients, you should treat them for years and years and years. So therefore, now we have, and that's new information, we have now a specific focus on the fast and very fast decliners. This is a study that was published by Królewski and a group, the Jocelyn group. And this is very, very interesting because now suddenly it is possible to find out what kind of patients, how do we define the patients in a study for kidney disease? If we want to have a study that is not running for 5 years, but we have a study that is running for 1 or 2 or 3 years. So here you can see that the very fast and fast decliners, they can actually be picked out from the whole patient group if they have a serum TNFi above something and an EGFR on another value. So therefore, we are now able to suddenly select the right patients that could come into treatment, because as a biotech company, we don't have time to make a 5-year study. We don't have money to make a 4,000 or 5,000 patient study. But this is what we are going to do. We are going to use this new knowledge to select the right patient group for a faster onset of action. And what are we looking for? So this is a fast declining. The red line is a fast declining patients where the degradation of the kidney can be deducted, and all declines, slow or fast, they are linear. That is the outcome of this gigantic study that Królewski published. So they're all linear. So therefore, we believe if we can find the right patients with these biomarkers, that we can stop the degradation of the kidney and save patients, save a lot of things. Economic, it would be tremendous, gigantic numbers that we are talking about, and patients could avoid kidney transplants and dialysis. Serodus is actually a company with a broad pipeline. So SER-150 is a small molecule, but we are developing that both in type 2 diabetes with fast decliners and also in type 1 diabetes fast decliners. And we also have a couple of small compounds that are peptides, SER-150 that we are aiming for retinopathy, and the SER-190 that is going for foot ulcer. These are anti-inflammatory. One is an IL-4 receptor agonist, and the other one is an IL-1 beta receptor antagonist. So once again, we are working with the anti-inflammatory processes here, not just thromboxane and TNFR, but also IL-1 and IL-4. So we have a broad palette of various compounds, but what we're looking for at the moment is to fund the next clinical study where we have intentions to start up in the first quarter next year. We do have people on board, but the private investors that have helped us until now, they will not be able to manage all the way through the first study at least, where we are talking about more than 10 million euro. So that was a very, very brief introduction to Serodus. So, and we, as I said, we are a virtual small company with no laboratories or something, and we have a lot of consultants working with us, but we are pushing our most advanced product heavily forward to an IND and an NDA. Thank you very much.